presume the ischemic heart disease in patients with essential hypertension until proven otherwise. Assess the patient's exercise tolerance with the focus on dyspnea or angina. Check the ECG for abnormal condition or ischemia and consider the stress test. If cardiac exam suggests valvular disease or myocardial dysfunction, consider echocardiography. Continue the current antihypertensive regimen prior to surgery. Review the antihypertensive medications for pharmacology and potential side effects. ACE inhibitors and angiotensin receptor blockers can be associated with severe hypotension during general anesthesia. Complications due to cessation of antihypertensive medication. Beta-adrenergic antagonist that will produce myocardial ischemia. Clonidine, if cessation is done, it will produce hypertensive crisis. Intraoperative management. Induction. Direct laryngoscopy and tracheal intubations can cause significant hypertension, tachycardia, and myocardial ischemia. Use of IV drugs cannot definitely suppress the cardiovascular responses to tracheal intubation. Management. In patients at high risk for myocardial ischemia, consider the deep inhalation anesthesia or injection of opioid, lidocaine, beta-adrenergic antagonist, or vasodilator to suppress the tracheal reflexes and reduce the autonomic responses to laryngoscopy. Intraoperative hemodynamic management. Patients with essential hypertension have an increased incidence of perioperative hypertension. Volatile anesthetics can attenuate the pressure response of sympathetic nervous system, resulting in dose-dependent decrease in the BP, systemic vascular resistance, and myocardial depression. Intraoperative hypotension may occur when the ACE inhibitors and angiotensin II antagonists were not discontinued 24 hours before the surgery. Vasoconstrictor treatment may require, such as low-dose vasopressors. No volatile agents or muscle relaxants appear to be more preferable in this patient population. Pancuronium has dose-related sympathomimetic and vagolytic effects, and one should consider avoiding this drug. Cerebral autoregulation, typically maintained between mean BP 50 and 150 mm of mercury. In chronic hypertension, the lower BP limit of autoregulation of cerebral blood flow is shifted towards a higher BP. The clinical consequences of this shift is an impaired tolerance to lower BP. Long-term antihypertensive treatment can help readapt to normal autoregulation of cerebral blood flow, illustrating the importance of the preoperative baseline evaluation. Monitoring. ECG, preferably 5-lead, to recognize the myocardial ischemia during periods of intense painful stimulation such as laryngoscopy and tracheal intubation. Invasive monitoring, arterial or central line pulmonary artery catheter are useful for extensive surgery or in case of left ventricular dysfunction or other significant end organ damage. Transesophageal echocardiography to monitor the left ventricular function and intravascular volume replacement in major surgical cases or critical condition of the patient. Postoperative management. Postoperative hypertension is common in patients with essential hypertension. Close monitoring of BP will prompt assessment and treatment is required to decrease the risk of myocardial ischemia, arrhythmia, congestive heart failure, cerebrovascular ischemia, and maintain the surgical wound hemostasis. Adequate management of postoperative pain. Pain is an important contributor to postoperative hypertension. Useful approaches to pain management include epidural anesthesia. Temporary administration of antihypertensive agents may be necessary. Medication should be chosen based on the patient's vital signs and coexisting diseases. One approach is to use the labetalol IV intermittently, 20 mg over 2 minutes. Temporary IV administration of antihypertensive agents may be necessary. Medication should be chosen based on the patient's vital signs and coexisting diseases. One approach is to use labetalol IV intermittently, 20 mg over 2 minutes, then double at 10 minutes intervals until the desired response a single maximal dose of 80 mg toxicity or a cumulative dose of 300 mg per day or infusion of 2 mg per minute initially, then titrate in a 2 mg increments every 10 minutes until the response or toxicity or a cumulative dose of 300 mg in 24 hours. In the presence of a low heart rate and or contraindication to beta-adrenergic antagonists, hydralazine is an alternative agent. Now, summary for the essential hypertension and anesthetic consideration. Definition. Essential hypertension, no secondary cause for hypertension can be identified, such as pheochromocytoma, hyperaldosteronism, Cushing's disease, or renovascular hypertension, aortic coarctation, essential hypertension, comprises 95% of all cases of hypertension. Classification. Normal is less than 120 systolic and less than 80 BP diastolic. Pre-hypertension is 120 to 139 systolic and 80 to 89 diastolic. Stage 1 hypertension, that is 140 to 159 systolic and 90 to 99 diastolic. Stage 2 hypertension, that is 160 to 179 systolic and 100 to 109 diastolic. Now, in stage 3 hypertension, it is 180 to 200, 180 to 170, to 180 to 209 systolic and 110 to 119 diastolic. Stage 4 hypertension, that is more than or equal to 210 millimeters of mercury systolic and more than or equal to 120 diastolic. Preoperative considerations. Review the medications, assess the baseline and end organ damage. In stage 3 and stage 4 hypertension and stage 2 hypertension with end organ damage, consider deferring the surgery for patient's optimization. Intraoperative considerations. Increase of perioperative hypertension and BP lability. Cerebral autoregulation may be altered. Postoperative considerations. Postoperative considerations, close monitoring and management of BP to avoid the myocardial ischemia and maintain the surgical wound hemostasis. Adequate pain management is very essential. Okay, thank you. We come to the end of this lecture.